All right, hi everyone. So this is a presentation on management of sleep challenges in allied health professions. I'm Sherry Causable. I'm a registered respiratory therapist. I have a certified certification in respiratory education. I'm a registered polysomnography technologist. I have a certification in clinical sleep health, and I'm a certified clinical hypnotherapist. So objective. So the reason why I really wanted to talk about this is because I've worked in several aspects of the world of the healthcare field. I've done EMS work from ages ago. I've worked in acute care and chronic care. And so what I wanted to do is draw a little bit more attention about how allied health professions in general are affected by sleep, are affected by the work that they do in terms of their sleep. So what I wanted to look at is listing the two common disorders that can happen, and what are the unique factors that are unique to the healthcare setting, and then listing effective approaches for reducing risk. Also, again, going over what normal sleep is and the management options. So what is normal sleep? So if you were listening to the previous talk, I went over this a little bit as well. And basically, it's that we acknowledge in general that individual variability is high with what we consider normal sleep. So let's say somebody in North America goes into their doctor and they say, listen, I eat my dinner at 10 o'clock at night, and then I go to bed about midnight, and I get up about 6 a.m., maybe 5. And then I'll go to work for until about, 10, 11 o'clock. And then I might have about a 3-4 hour nap in the middle of the day. And then maybe I'll go back to work for a little bit, and then I'll carry on doing the same thing. A doctor in North America would think you're crazy, because that is something that we do in Europe. So when you look at the factors that influence why and how people do things, they're influenced by geography, culture, demography, the age, and gender as well. So in general, when we look at all of these factors and what we consider is normal in a 24-hour period for what we want out of good sleep for people, we look at what the American Academy of Sleep Medicine has sussed out from all of the data. And their determination is that to support optimal health in adults, we need 7 to 9 hours. And that's the basic general rule that they go with. Now, of course, there's going to be people who are going to be on either side of that. They're going to be between the 5 and 7, and then they're going to be up between the 10, 11, sometimes 12. And those people are, 5 to 10% of the population on one side or the other. So what is a normal polysomnography? When we look at whether your sleep is normal or not in polysomnography, or the study of multiple parameters of your sleep, we are looking at the time, so the normal sleep period says 7 to 9 hours, and we want to see about 5 cycles of sleep. Now, each cycle has got 2 distinct sleep types in it. It's got non-REM and it's got REM. So non-REM is broken down, of course, into the 3 stages, N1, N2, and N3. If you look in some older literature, you might see N4 as well. And that was determined. They basically rolled all of deep sleep into N3 now and got rid of N4. It used to be that N4 sleep had to have more than 30% of that epoch, or the screen had to be delta waves. And they determined that there was no need to do that anymore. So the time spent in N3, you'll notice when you look at a polysom is that it decreases over the night, and the time in REM will increase. So why do we have these stages? Stage 1, when you look at stage 1 in general, it's a transitional stage. It's that transitional stage between wake and sleep. You'll probably find a lot of people driving late at night and long stretches of road going in and out of stage 1 sleep. It's that slight doze away, or even daydreaming is where we see this. And it's the least amount of each sleep cycle. It's just about, a few minutes, if that. And then we will cycle into stage 2. It's 50% of the sleep cycle. Again, in general, depending on your age, the older you get, the more of N2 you get, and the younger you are, the less N2 you have, and the more N3. And when we look at N2, we find that in that sleep stage that there is typically a sorting of useful memories for easy retrieval. And this is the general theories that we find there. Deep sleep in stage 3 sleep, it's only about 20% of the total sleep cycle. Typically, again, with younger people and then kids, it's quite a bit more. Responsible for body repairs, we have growth hormone that is secreted in this sleep stage, and it's also involved in memory consolidation. So there's going to be some hippocampus involvement with this one as well. REM sleep, it's about 20 to 25% of the total sleep cycle. And of course, there's 2 phases, that phasic and that tonic. So if you might have seen in movies where people are dreaming and they're trying to kind of show that they're dreaming wildly, they'll show that their eyes are moving underneath. That's phasic REM. Tonic REM is where the eyes don't move at all. Quite often, when we look at phasic REM and we're not sure and people have some complex brain activity, the phasic piece of the eyes would be one of the ones that can basically nail it, that, yeah, this person's in REM and not in stage 2. The stage 2 in REM without the eye movement can sometimes look quite a bit alike. So this is what all of that put together looks like. If you look at the sleep duration throughout this is like an 8-hour sleep cycle. And this is, to me, it's like a dance. So this person starts off here at the beginning of the night. So sleep onset, normal sleep onset is about 20 minutes. And then each sleep cycle is about 90 to 110 minutes or 120 minutes. So depending on the person. But they'll transition after about 15, 20 minutes down to stage 1. And typically what we'll see with people is it won't just be wake to N1, it'll go wake N1, wake N1, wake N1, and then down to stage 2. And they might pop up again a couple of times here or there to wake, but often it's just a little bit of an EEG arousal, not a full wake. And then there's the stage 2, and then the stage 3 where they have that lovely growth hormone, and then they come up into REM. Now, coming up into REM doesn't mean that this is a lighter stage. It just means that it is a stage all on its own. REM is a completely different beast than non-REM. It looks different. The body reacts quite differently. We don't have good body temperature regulation. Muscle tone is nil in REM normally. When you have movement disorders like REM behavior disorder, they actually have muscle tone and they can move around and act out their dreams. So that's considered abnormal. But yeah, so it's quite different where, in stage 1, 2, and 3, where you have some, regulation, like normal regulation that's similar to wake. The only thing that we do notice is that the muscle tone from N1 down to N2 to N3 and then finally to REM is a decreasing muscle tone that happens. Now, in the first part of the night, you'll notice that stage 3 is predominant. So you have stage 3 quite a bit here. And then in the last stage of the last part of the night, you're going to get your REM sleep. So this tiny bit of REM, totally normal. It increases and then increases and then increases and then increases here. Here, this person's just come awake. And what you'll see is these little wake ups that happen here, very, very common, but people will often have a quick wake, which can be 15 seconds, 16 seconds or more. That's considered wake. You wouldn't remember it and maybe you fall back asleep, or maybe you believe that you're laying there and you're thinking about your dream when often people are actually still dreaming. I've had people argue with me in full stage 2 sleep, after they've, watching them in stage 2 sleep, going to wake them up. And they're saying, oh, geez, finally you came in and I was waiting for you. You were in solid N2 sleep the whole time that you were not awake. Oh, no, they would swear on a stack of Bibles they were awake. So what is an allied health profession? So when you look at allied health professionals, I actually had to look this up because I didn't know who was all included in it. We seem to be, kind of a mixed bag. But basically, if you look at the range of people that we have here, RTs, OTs, PTs, lab techs, assistants, radiology techs, medical sonographers, these are like people that are supporting the main structure of the system without our type of support and our specialties that there's difficulties in kind of determining exactly what's happening with people. Of course, you see us in private and public sectors, and we're acute or chronic, we're specialty, we're rehab, we're palliative. And we can be all of these things in some scenarios, like I mentioned with my current role in the community as a respiratory therapist. We work a lot with chronic, specialty, rehab, and palliative situations. And what we noticed, I think, was that since COVID, there's been a huge strain on our healthcare system of more people in the system. And as a result, I'm not sure what the response has been there in the US, but we're finding that the doctors and the nurses and the main framework of the system is pulling more of us allied health professionals in to support and finding that our role is expanding more than I've ever seen it before. So what are the unique demands of a healthcare system? So this is really key, and this is really key to how it affects sleep and quite uniquely to the healthcare professional. Care is 24 hours a day, right? And it is adrenaline and it's cortisol filled. So even if you're not running to a code in acute, or instead you're working with somebody on awards and you need to, do your assessments and you need to get reports back to people. And you need to make sure that everything is done for this person in a specific time frame, because that type of care is really crucial that this person gets it in this time frame. That really doesn't allow for you to focus on yourself very much, because your focus is so constantly on the outside and supporting it so that people don't fall through cracks and that people remain stable or become more stable. And then fatigue. I don't know any other profession that looks at fatigue as much as like a badge as healthcare does. I mean, you look at the way doctors are trained just in general, and the rounds and the how they train, the dedication and the excellence culture that is expected doesn't take into account, but we are dealing with the same human body that requires a rest and regeneration phase to work optimally and reliably. And also, the system is not flexible to circadian rhythm resets between shifts. You have to get these quick turnarounds, or you get given the shift of days to nights or nights to days, whether it works for you or not. There's no real choice in that matter. And then the environment of artificial lights and chaotic activities. So there's no ability to bring yourself back into that state of calm unless you are given the moment or taking the time to find a quiet place that might be a little darker or, calmer light, and maybe breathing or maybe listening to some music or something like that. But that typically has to be on that healthcare worker, and with the fatigue of dedication and excellence culture, it's difficult to substantiate that for a lot of people. And then finally, this is the big one for all of us, I think, a bad day at work can be a loss of life, even when we do everything right. I can't tell you how many days I've had that one. Sleep disorders, most common to allied health professionals. So when we look at the specific disorders that stand out most, is the shift work disorder. Now, shift work disorder we find in all different types of professions, not just in healthcare, but specifically in healthcare. This one stands out specifically because of the type of stress that we are exposed to compared to other types of work. And it's related to extrinsic circadian rhythm disturbances. So in other words, artificial light exposure on the intrinsic biological clock. And insomnia with just that hypervigilance that just, doesn't allow us to make that consciousness shift from wake to sleep, because we're so used to and so practiced at being ready, almost in that PTSD type state, or perhaps in that PTSD type state. And then, of course, work-related trauma, where we're processing post-trauma. So shift work disorder is basically defined as a daytime sleepiness and or insomnia, so one or other, for a period of 3 months in the presence of rotating shifts or night shift schedules. So it doesn't have to just be related to night shifts. It can also be related to rotating shifts in general. So when we look at what the biggest deciding factor in whether you develop shift work disorder is or not, it's this master circadian clock and what it is exposed to. Is it getting artificial light all of the time? And so it's always exposed to light. And then when it's always exposed to light, it's not getting the pressure for sleep because it's not secreting the melatonin. The master circadian clock influences these sleep-wake cycles. It changes the hormonal activity, like I mentioned previously in the other body clocks, and which changes your body temperature rhythm, and then also eating and digesting, and then whether you are going to digest properly. So in essence, exposure to light gives you that serotonin production. It makes you ready for things, activity, and it is a happy hormone. In some cases, it also can just help make you super ready. And when you have that also threat that comes up, then there's additional hormones that'll come in there with that adrenaline and cortisol. Exposure to dark is that melatonin production, and of course that pressure to sleep. So here we are. Again, this is the same diagram I used in my previous talk, basically about the interaction between the body clocks. So keeping in mind that this light piece, the external stimuli, external stimulus that we have on the central clock, which is in the suprachiasmatic nucleus in the hypothalamus, is the biggest influencer of this central clock in the brain. So it's the biggest influencer on the body. So when the light is on, it sends a signal to all the other peripheral clocks to say, be awake, be ready to digest, be ready to pump faster, increase the blood pressure, things like that. It also influences that body temperature. So when you're sleeping, you're not regulating it as well. And perhaps you may be a little bit cooler because you're probably going to be covered in something in some way. You're going to be protected by a blanket or otherwise. And then when you're awake, increasing that. So this is a beautiful way, I think, to kind of put all of that together and how it translates in what happens to our bodies over time. So in the upper part of this circle, you see this light on. And so we have more serotonin being secreted that is telling the body to be awake and to be alert and coordinate. And you got your fastest reaction times, you got your highest alertness here. You also have your fastest increase in blood pressure and the highest body temperature. In the lower part here, you have that melatonin secretion. And of course, it's interesting. You've got your lowest body temperature, which we would expect. This one I didn't expect. The highest blood pressure. So that one I'm not sure about. That kind of goes beyond the scope of this talk, but I thought that one was quite interesting. And that one looked at about 2000 hours. So it'd be interesting to see exactly what the case is for that. That's another talk, I think. But when you look at this, master circadian clock, I think it's really interesting. If you see the cortisol release at 6 a.m., it's almost like an internal alarm that happens. So if you've ever had that where you're like, oh, I'm just awake. I'm just awake in the morning. That might be an indication that the cortisol is being released at that time. And if this isn't the time that you want to be up, then perhaps your master circadian clock has been shifted. Perhaps that instead of having this being nice and flat like this, then perhaps it's more on a diagonal like this. So keeping in mind what you may have done to shift that clock. Are you eating in the middle of the night? Are you going to bed too late? And so on and so on. So we have different levels of a circadian desynchrony that happen basically. So if you kind of go in a little bit deeper onto what happens, so you have this jet lagging type effect, just misalignment of internal times and external times happening. So during the day, if you look at here, the external timing, everything's on, everything's working great. But if you misalign them, so during the day you're not eating and you're sleeping, maybe as in shift work, and you're exposing yourself to light somehow by not controlling where you're sleeping, then you're going to affect these clocks in an adverse way. You're going to shift them. All of these things like your appetite, your blood pressure, your pressure to sleep, all of it's going to change. And then all of that goes down to the tissue level to cause a desynchrony at the tissue level. So it's quite a domino effect when you look at what you're doing here. So if you're looking at sleeping during the daytime when the sun is out, it is really important to make sure that your daytime sleeping looks more like nighttime, so that it looks like that there's no light exposure at all, so that when you won't have light, when you don't have food, and when you're sleeping, that all of the clocks are being influenced in the way that they need to be influenced. So now instead of desynchrony, you have synchronization happening, and you have this overall body pressure to sleep. So shift work disorder and allied health professionals. Let's mash the two together. We've got this shift work disorder that happens where we've got these circadian clocks that are working off of their time, their jet lags, so to speak. And now we are going to add in stress of patient care. We're going to add in cortisol. We're going to add in the stress to perform, the perfection excellence, the fatigue, striving for fatigue and working through it and getting it done. So it's really interesting when you add in these two. If you look at the statistics here between people with just shift work disorder and allied health professionals with shift work disorder, 2% of the general population meets the criteria for shift work disorder. That's compared to 10 times that or more of allied health professionals. That's how much the stress of being a allied health professional impacts shift work disorder itself. That's huge. That's incredible to me. So the other thing too to look at is this overnight occupational and neurophysiologic impairment. It's most strongly correlated to insomnia. So when you have people who are talking about difficulty getting to sleep or staying asleep, the chances of them being occupationally and neurophysiologically impaired is quite high, and it's usually related to this insomnia picture. And among healthcare workers in general with sleep work disorder, insomnia is linked to these functional and cognitive impairments. It's no wonder with 20 to 30%. And then, of course, with greater incidence of insomnia, never mind the work and what happens with the work, what happens with your body. You get metabolic disturbances because those inner clocks, those peripheral clocks are out of balance. You're not metabolizing when you should be, or you are metabolizing when you shouldn't, and keeping you awake. And then the brain's not being washed out. You're getting interrupted sleep. So the brain is getting clogged up with all of this stuff when it's supposed to be resting, regenerating, quickly sorting, easy retrievable places. You're now getting these clogged up brains where you have to work hard to get through it. So that can result in feelings of depression and anxiety. And of course, suicide is also a factor to consider. So managing shift work disorder, what do we do about this? The American Academy of Sleep Medicine put forth a really interesting tip sheet for healthcare workers. So if you go onto the American Academy of Sleep Medicine website, you'll be able to find a tip sheet there to prioritize sleep and manage fatigue. Keep in mind, this is a general tip sheet for the average person. It is not always taking into account the unique factors for you. So you can look at these things, and if it resonates and you may find that it is helpful for you, then you can look at doing one or two of them. And if it helps, great. If not, then of course you're moving ahead to working with a health professional. The ASM in general just suggests to alleviate the stress load before bed, which would, optimize your hormonal pressure to sleep. And then, of course, minimizing the outside stressors and stimuli. And light being the number one, because it does have that impact on the melatonin, which is our hormone that gives us the pressure to sleep. So what's the role of diet and exercise? If we can control these factors, and yes, we can control what we eat, when we eat it, timing, duration, amounts, all of that is crucial, because we look at if we're eating later and then we go to bed early, then and it's a higher fat sort of meal, what are you asking your liver to do while it's supposed to be resting and cleaning itself out? You're actually asking it to work, and that's going to feedback on your master clock and keep you awake. But you have these abilities to control these things. So things like exercise and calm activity, low light, positive emotions, those things all lead to serotonin and dopamine to release in a way that is promoting a state of alpha and calm. So alpha being that beautiful brain activity that makes you feel like everything's wonderful. So that lends me to giving yourself a buffer. The American Academy of Sleep Medicine suggests to give yourself 30 to 60 minutes before you head to bed. I suggest probably a little bit higher. You want to, again, look at what works for you. If you take a bit to really sort of, calm down, or you notice that drive between work and home really does help you, then you are a person where a buffer is quite important for you. And you're probably going to look at more of a bigger buffer. It just allows you that switch over, that coming down, that buffer time is not being done solving problems or on the phone and doing this. It's about calming activities. It's about doing what you need to decompress. And healthcare workers often dismiss this, either purposely or, quite, due to fatigue, things like that, where they just don't give themselves that opportunity, or they fall asleep just so fast they don't have time to kind of process and sit quiet with their body and try and balance that mind-body piece. And then, of course, inability to quiet the mind. So if we don't do this, if we don't give that mind the time to kind of gear down, those negative thoughts are just going to keep coming up when it's quiet. When it's dark in the room, people say, I have this mind racing. Well, and that's because when the lights were on, we didn't consciously stop to make sure that we put the focus on this calm to allow those thoughts to gear down, because the mind won't be ignored at all. It's going to come back up when things are quiet and say, hey, you forgot to turn me off. So that's your cue to do what you need to do to, to calm yourself down. So breaking old patterns. So when you associate one bad night, you say, okay, I've had one bad night, and we are predictive creatures. We like to understand that if 1 + 1 = 2, then 2 + 2 must equal 4, and so on and so on. So we learn by experience for the most part, but what we don't understand sometimes or pay attention to is that the past doesn't equal the future. And so when we have one bad night, we look to see, will the second night be bad? Well, again, where your focus goes, your energy flows. So will it happen? Will it happen? It's kind of like if you were to buy a new vehicle. Let's say you buy a new vehicle, beautiful color, never seen this color before, great color. You're like, wow, this is great, unique car, awesome. You start driving it, all of a sudden you see 3 other cars just like it. You never saw that before. But because your focus was on this unique thing, all of a sudden it pointed out all of those cars that were there before, guaranteed. So it's the same thing when you relate this to going to bed. If you look to see, will I not fall asleep again tonight? Chances are you won't fall asleep again tonight. So what we suggest is that you break that pattern, you break the predictability of that pattern by reassociating the bed with positive, repetitive ways. And part of that is stimulus control therapy. And we'll go into that a little bit later. So how do we make that mental switch? How do we slow the brain down? So these are some of the ideas that people will use. Climbing into bed with food or a coffee just at the end of your shift, probably not the greatest thing to do. What we're looking at is all the things that relate to calming the body down. So think about turning off the lights in a house one by one. If you go around your house and you turn the lights off, this is what it would look like. So maybe you listen to a calm book one night. Maybe another night you listen to a guided meditation. Maybe another night you might take a bath. Notice what works for you, and you can change it up. But it's about being consistent, about making the mental switch every night. This is a really interesting study that when this doctor did on, Dr. Gupta did on photic stimulation. So what are the things that we can do to help us stay awake when we're trying to do our work? So if your internal body clock is a little bit off and you need to perform a task, and then you also want to, you're resetting that body clock so that you're most awake when you're supposed to be working, and then you have that pressure to sleep when you finished your shift. What this doctor did is, there's medications that we can use that will help the stimulation, like keep the mind awake, things like caffeine and modafinil and things like that. But they can have some, negative side effects, and then they linger on sometimes as well, especially towards the end of a shift. If you're drinking lots of coffee, good luck getting to sleep. So what he looked at is light stimulation. So basically applying light to align that inner circadian clock, that master circadian clock, just before going on your night shift, in an attempt to avoid the adverse effects of these hypnotic agents. And he had some success with it. The interesting thing that he noticed is exposure at the wrong time could actually make things worse. So you really have to know a little bit more about where somebody is in their their sleep-wake phase, which can be challenging. So going into these hypnotics, like I was mentioning before, there's these hypnotics and sedatives that can improve total sleep time. The problem with these is that they'll often keep the sleep, they'll consolidate it. So there's less wake-ups, less interruptions, less what we call EEG arousals or interruptions of that sleep pattern. And but they don't often allow you to either go into deep sleep or they will push it off. So managing light exposure, of course, that's a big one that goes back to melatonin production. If you're going to take melatonin, timing and dosage are so important. I have so many people that take it saying it doesn't work. It doesn't work. But do they know why they're taking it? So if you have insomnia, that is sleep onset insomnia, in other words, you have difficult getting to sleep, then you're going to take melatonin. That's just a regular formulation, and you may take a higher dose of it. So normally we'll see people take up to 15 milligrams of it, but you're taking it for that sedative effect, and you don't really care how long it lasts because it's the getting to sleep, that transition that you're having difficulty with. If you have middle insomnia where you wake up middle of the night or you wake up too early, then you're going to take a sustained release melatonin and you're going to take a smaller dosage. You don't necessarily want a sedative effect. So melatonin in those higher doses being sedative and then the lower doses being a circadian rhythm realignment, you're going to take the lower dose but sustained release, so it stays in your system like your normal body would be producing that melatonin. And just understanding what it is you're trying to fix is really important about what you're going to pick, not just saying it doesn't work. There's lots of different options on the shelves. So managing the fatigue, and this is the stimulants I was talking a little bit about. So of course, timing's everything. So if you are trying to use caffeine to stay awake on a shift, it's most effective in small amounts, but it's just in the first half of the shift. The interesting thing with caffeine is the more you drink it, the more you can not be as affected by it. So you get tolerant to it, just like a lot of drugs out there. But what we find with alertness in general is that if you want to maximize your alertness, keep it in the small amounts so that you don't build that tolerance, and keep it in the first half of the shift so it doesn't affect your ability to get to sleep when you're finished your shift. Exercise is a good one. It brings on the natural hormones of your fight-flight response. So you want to do go for a brisk walk in the middle of your shift, or up and down the hallway if you need to, or up and down the stairs, wherever you need to kind of, get the heart pumping a little bit and use some of that internal pharmacy that you've got working for you. And it can also relieve stress at the same time while managing your fatigue. The other one is eye movement. So if you look at the eye movement going back and forth, so if they tell you when you're driving to keep your eyes moving, is because if you don't, you get a narrow focus. You get focus on the one piece in front of you and you lose your peripheral vision. If you move your eyes side to side, that keeps you in beta. It keeps you from going into alpha, which is that narrowed, lose your peripheral vision piece. And it's useful to help you in reactivity and maintenance for alertness. So great for drivers and also great for healthcare workers. Insomnia disorder. So much like this poor little owl, you have trouble getting to sleep, staying asleep. Daytime consequences are definitely associated with it. And it can't be attributable to environmental circumstances or an inadequate opportunity to sleep. There is several different sleep disorders that take those into account, and those are usually self-sabotage. But this is an international classification of sleep disorders definition, and this is typically what we look at when we're trying to define insomnia. We have both acute and chronic forms. everyone has had insomnia at some point in their lives. It is a natural human thing to do in the acute form. When it's chronic, when it persists for at least 3 months at a frequency of at least 3 times a week, then that's not quite a normal thing. So there is natural tendencies to be born and with the closer to your insomnia threshold. So it doesn't take much to kind of tip you over into insomnia type symptoms. And then other people have this huge gap between their insomnia threshold border and where they naturally sit. And so you just kind of have to understand who you are and understanding the factors that may bump you into insomnia and looking at how you manage them. Some things you can't change, like age and gender and economic status and things like that, but you can manage how you manage your stress, your perception, in other words. If you look at prevalence, just in general, of chronic insomnia, so in general population, it's 5 to 15% of the population. And among healthcare workers, it's estimated much higher, but we don't really know exactly. I couldn't find some actual reliable data. It was all over the board, but we know it's much higher. Insomnia, it's a component of that shift work disorder, but it can exist independently in healthcare workers not working or no longer working with circadian rhythm shifts. And it's also a risk factor for mood disorders such as depression, poor quality of life, and of course that increased risk of suicide. And that goes right back to the ability of the brain to rest, restore, clean itself out at night. It just doesn't get the opportunity to cycle through those sleep cycles like it's meant to do. So it gets, you get stuck, you can't make connections, everything feels like a chore, it gets difficult. So this was an interesting review that was done. It was just done, the study started just before COVID, and of course, COVID started, and during COVID, you know, they were looking at rates of insomnia. So this study really lends to the impact of the stress in healthcare on insomnia. So the rate of insomnia disorder before COVID was 44.5%. During COVID, 64%. That's incredible. So if you look at that, I mean, insomnia disorder before 44%, I mean, that's pretty big. That's a lot of insomnia in supposedly healthy people not going through a pandemic. And then you add on 20% to that. Well, that's clinically significant. So you look at the impact of what COVID had just on our sleep quality, and you look at sleep quality, if we are impacting the immune system as a result of impacting the overall health and the ability of the brain to manage the overall system, well, then we're at a disadvantage to manage fighting an infection. And, you know, the interesting part with this too, that really kind of shows the impact of the healthcare workers and the stress that comes on in a health-related major event, that the difference between daytime and nighttime shift workers there was no difference. It was the same between both. And typically, we see it much higher in nighttime, people who work night shifts. So the clinical practice guideline for insomnia, and I've stated this before, is the cognitive behavioral therapy for insomnia. So it's their strong component. And then, of course, they can also, from a conditional point of view, you can also use multi-component brief therapies such as behavioral therapy for insomnias for treatment. And they're, again, more readily available and often more economically feasible for people to use. They can use stimulus control as well, sleep restriction therapy. There's a relaxation therapy. And then understanding that sleep hygiene by itself as a single component for the treatment of chronic insomnia disorder is not recommended. And that's because when you look at all these, they talk about multi-component because we are unique individuals. And so we're trying to cover all of the aspects that are going to influence people in their sleep. So insomnia interventions, just looking at that cognitive behavioral therapy, it's a first-line treatment. And so basically, when we look at the different types of behavioral therapies, it's that stimulus control, relaxation, education. Education being one of the key things. When you can understand exactly what's happening with your sleep, you understand what controls you do have, it really empowers you, gives you that opportunity to come out of that fight flight. And this is where CBT kind of focuses on that cognitive piece, where we can change the thoughts and that I don't have any control over this, I don't know what's happening, to I understand what's happening. These are the things I can control, and I can create significant change when I do this, perhaps. So looking at one of these relaxation therapy, this is one of the behavioral therapy techniques that we use for insomnia. And it's the two different types, the somatic tension. So progressive muscle relaxation is one that we'll use for induction, actually, for hypnosis, because it is so good at bringing people into the present moment using their bodies. So it basically uses attention focused on specific body parts, typically from the top of the head down to the tips of the toes, body part by body part, and envisioning a state of calm with an intent to relax each muscle, and that's all you're doing. So it's really helpful for some people who have quite an active mind, because we're giving their mind a task to do, and we're keeping it present in the moment to do it. And that helps them stay out of anxiety. It helps them stay out of that sympathetic mode, that fight flight piece, and come back in the calm state. The cognitive arousal reduction, so guided imagery training, meditation, this literally is about helping people see that the imagination piece, how powerful that can be to bring you into that calm state that you're looking for to help you with that transition to sleep. So if you're in this high fight flight stage because you've had, you've worked in acute care and you've got these codes running and things aren't going great, and you don't have the supplies you need, or you don't have the people, and you're running short, and there's all kinds of things that happen. And then you come home and you're supposed to just let that all go. So what cognitive arousal reduction, it gives you an opportunity to use the mind in an imaginative way. So we take away the need to react, and we give you an opportunity, a space, time to imagine what it is that you want instead. All these things that can possibly support you in all the ways that you need. And when we do that, we help people bridge that gap between that high arousal of the brain to the calm. So sleep restriction therapy is another one that can be used for professionals. We don't use it for safety critical occupations, typically, because what we do with this therapy is when people come in and they say, oh, I only slept 4 hours last night. We know when people say that, they usually think in all of my years of working at the sleep lab, when someone said, I only slept 2 hours last night, maybe 2 people out of all of that were right. Every other one, there was more sleep that they didn't know they were sleeping because it wasn't good sleep. They didn't feel like they slept, and they were more focused on the wake-ups than they were on the actual sleep. So what we do when we do a sleep study on somebody, and they actually have more sleep than they're telling us they have, but it's broken. It's a lot of wake-ups in between. We'll say to them, how many hours of sleep do you think you got? They'll say, okay, I got 4 hours sleep. So we say, okay, tonight you get 4 hours sleep. What time do you want to be up in the morning? Say, okay, I want to be up at 6 a.m. Perfect. You're going to bed at 2 a.m. So we keep them up. We keep them up until 2 a.m. and they sleep until 6 a.m. They're going to hate us because they're exhausted, because we know they got more than 4 hours sleep. But what it does is it consolidates that sleep. there is very little wake-ups typically during that sleep because they are sleep deprived. The brain is very good when it's deprived at getting what it needs. And so it consolidates that sleep into less interrupted sleep. And then we start adding in a half an hour at a time. Now, this is up to the healthcare professional to do that, and it's monitored by healthcare professionals. We don't do it with people with mood disorders, and we don't do it with seizures because this is sleep deprivation to start. And until we move to a part where they find, okay, I'm waking up restored. Now this is my sleep time. And now they've set a new schedule. The stimulus control. This is basically about going to bed only when you're sleepy, only associating the bed with sleep. Otherwise, when you fall asleep in other areas, you're going to assume that there is no need, there is no particular function for any one place, that any place could be a place to sleep or any place could be a place to wake. Because our brains like to predict, if you give them that predictability, they'll love you for it. And you'll get that pressure to sleep in the right places instead of the wrong ones. And this is why you want to wake up the same time every morning. Refrain from the daytime napping if you're having an issue. And if you're going to have a daytime nap, have it super early and limit it 20 minutes. So less stress, more sleep. The more you practice this calm state of mind, the stronger the mindset gets. And of course, the stronger your mindset is, the more resiliency you have and the lower your stress. And then, of course, this is going to translate into somebody who can shift their state of consciousness from a state of high to a state of calm. There's all different kinds of things that you can use for this. There's apps. Calm is a big one. People notice. There's another one called Napflix. I thought this one was funny. It uses visual and audible monotony. So it basically, in essence, bores you to sleep. Monotony has that beautiful effect of bringing you into alpha or transition to sleep. So why is alpha state so important? Well, it's the doorway to sleep. This is how we transition from wake to sleep. So when you look at things like activity, exercise, problem, things like that, when we're trying to keep people in a deep state of sleep, we want it so that they have been part of that transition into sleep. So you have to pass through alpha. So if someone who is super, super tired, like say a healthcare worker comes home at the end of the day, they're super tired and they just crash. They literally crash in a few minutes. Well, they go through alpha, but it's super, super fast and they're not aware of the effect and that they need that to go into theta, which is that sleep. So when wake after sleep onset occurs, so in other words, middle insomnia, so an hour, half an hour, 2 hours into sleep, and they've gotten just enough sleep, just enough not to be exhausted. Now they're not aware that they can transition through this. They can't force through to theta. They can't force through to sleep with that exhaustion, and it results in this middle insomnia. So what we do is we train people in starting that alpha state and initiating it so that they're at the doorway to sleep and they transition right through with ease and calm. One of the things we do to help people with this at the very beginning when they're learning these cognitive behavioral techniques is pair it with pharmacotherapy. And there's several different kinds, and depending on availability and cost and patient preferences and the doctor, it depends on which one you get. And so what are the expected outcomes of intervening into insomnia? So we want to increase our total sleep time. When we increase our total sleep time, we're getting that 7 to 9 hours. That's going to give you that optimal health outcome. Sleep quality, we're going to have less wake-ups during the night, consolidated sleep, so you can cycle through those sleep stages and get all the benefits of each sleep stage that you're supposed to get. It's like a dance. You have to go from N1, 2, 3, REM, 1, 2, 3, REM. You don't get to skip. So if you get interrupted, it's like playing Monopoly. You go to jail, You don't go fast go, you don't get collect $200. If you get woken up at stage 2, you're back to stage 1. Get back woken up at stage 3, go back to stage 1. And your time to REM is interrupted. So you might not achieve your first REM stage with good sleep until much later in the night. We realign our circadian rhythm. So we are less exposed to things like metabolic disorders, poor sleep disturbances, mood disorders, things like that. And quality of life, when you feel better and your whole body is working for you, instead of trying to catch up to what you are doing and what you're exposing yourself to in your environment, you don't feel like you're on that treadmill. And then all of that lends into mental health and that cognitive performance. If we don't clean out that brain properly every night, we're not doing our jobs the way we want to. And in our field is just, it's almost unheard of in a culture of fatigue excellence. Yeah, it doesn't really compute. And then, of course, your accident risk, you're not going to be aware, you're not going to be on like you need to be. And you might miss those things and transition into sleep when you're driving, perhaps home from a shift. And then sleep efficiency, that goes back to the sleep quality. So how are you cycling through those sleep stages? Are you getting enough of each one? And then those GI symptoms, when you are in a stressed state, nothing is working right, and that is affecting that internal clock, which is shutting off the metabolism in times when you need it to be on, and vice versa. And then excessive sleepiness when you should be alert, and excessive alertness when you should be asleep. So you want all of these things working for you, not against you, and it is possible. So in summary, just awareness and sensitivity needs to be put there and elevated in importance on the quality of work and overall health, so that we can confidently perform our tasks while still staying healthy. That's the important part. We can do our jobs and be healthy if there can be things like, paying attention to what we're exposing ourselves to, talking to our employers about what we're exposed to, and then, possibly getting a decompression time, or, trying to change some of the key influencers, such as those stressors and the trauma impacts and the light and things like that. All of these things together might make a big difference. And these are my references. So I want to thank you so much for listening today, and I hope you learned something.